Alright, so we might as well get started. For those of you that have or haven't seen it so far, this is just like a couple of quick sort of scenarios to go through to give you an idea about common heart-related problems that you'll get on the ward, and just some ways of thinking about dealing with it. If you've got any questions, it's a small enough group, ask, interrupt, I don't really mind. If they're not related to this, you can still ask and interrupt, that's what it's for, all right? So we'll start, because everyone hates the ECG, we'll start by looking at it. The importance of remembering which arteries go where is pretty relevant. So why do we care about right coronary infarcts? What's the problem with right coronary infarcts? Yeah, good. And what happens when you bust that?
You can get ventricular rhythms if you're not getting the atrial.
Yeah, how fast are those?
Yes.
Yeah, right? So it does make a little bit of a difference. For what it's worth, when people talk about inferior infarct or changes, lateral, septal, anterior, that's sort of that bottom right grid is what they're looking at. Okay, and they reflect particularly the right coronary, the LAD or anterior interventricular, whatever you want to call it, and then circumflex. Right? So why don't we start? You're always going to get pages like this, just fast heart rate, you have to review. And you go up and you see someone that's in their mid-70s or something, and their heart's going a bit fast. She looks otherwise well, and eventually you get an ECG. So, who's up first? What's that? Someone describe the ECG to me. Let's go back to, I was going to say go back to med school, but it's been med school for a few more years. How do you describe ECGs? Sorry?
First is right.
Sure, yeah, that'll do. It's not super fast, but it's not too slow. Cool.
Yeah,
all right.
that's irregular.
Yeah. If it's irregular, what do you have to look for?
Pwaves.
Where are they?
Not
there.
They're not there?
No.
Can you see Pwaves? Yeah.
No. Yeah.
What are like these little things? They're all Pwaves. Okay. What's wrong with the Pwaves?
They're not aligned with the ventricular rhythms.
Good. Yeah.
It's complete dissociation.
Exactly. So you don't have conduction between every P wave and the QRS complex. So what is it? Sorry?
Heart block.
Is it heart block?
If they're not aligned with
Is there something else that's irregular? It's not heart block.
atrial flutter.
Flutter could be.
It's regular, isn't it?
Flutter tends to have a very specific pattern underneath. Yeah, what else could it be? AF. AFib, atrial fibrillation, right? So, atrial fibrillation.
So you can have P waves in AF.
You do have P waves in AF, it's exactly what it is. So AF is basically the...
Sorry, I thought you had F to P waves.
Yeah.
That was what?
Yeah.
No, so what you actually get is, you still get atrial contraction going on. So you still get electricity that's going through. What you don't get is every electrical contraction of the atrium coincides with the ventricular contraction. So you don't necessarily get the electricity that will go all the way through. So you still do get intermittent P waves throughout. It's just that your P waves and your QRS complexes don't join. So you get some that do.
So what's the difference between that and third-degree heart block?
So third-degree heart block has to be specifically that there are no P waves that will conduct through the QRS complexes. So what tends to happen here in classic AF is that essentially think about it like your normal heart rhythm is atrium ventricle, right, with the conduction wave through. In AF, something's irritated it, specifically some of these causes for new AF. Who would have thought, right? So something's irritated the heart, whether it's a direct insult on the heart, whether it's an electrical insult, an inflammatory cytokine storm, an infarction, whatever you want to call it, right? Something's irritated it. And so the atrium is pumping away at some undefined rate, and every now and then you get one of those electrical conductions that actually does go through, transmits, and then goes down into the ventricles and gives you a ventricular contraction. Right? So sometimes you'll get a nice atrial filling, a nice pump of the atrium, and then a nice ventricular contraction that follows. Sometimes you don't. Sometimes you just get a little bit of an odd electrical anomaly that's occurred somewhere. Doesn't really contract the atrium well, but it goes through and still gives the ventricle tap. Yeah? Happy with that? AF? Causes, that's all new. That's for new AF, right? So new AF, these are some things people tell you to think about. How useful are they? I don't know. You'd search for it anyway. Most of the time it doesn't really matter. Old people just get AF, right? So one question that will always get asked is if that before was someone that was running at 70 odd, right? It was like the initial stem, they're running 130. What do you do?
You need to think that initially if they're hemodynamically stable or not.
Yeah, okay. So we go back here. Is this person hemodynamically stable?
Looks good.
Yeah? What makes you think it looks good?
Well, it depends how long you think they're gonna, like, if there's more background thinking, you think it might quickly deteriorate, but at the moment.
She's sitting in bed just talking to you.
Yeah.
Doesn't even know why the nurse is there.
Yeah.
Why
We don't know what her blood pressure was, but assuming she's doing okay, she's not symptomatic.
Yeah.
So she's stable.
Yeah, right. So I'd argue it's relatively stable. Yeah. No signs of shock, right? So no signs of shock. What do you do? Because you've got a page about a fast heartbeat.
So you want to know if it was older than you or
Yep.
paroxysmal.
Sure.
So if this person had a previous.
Let's say it's old. Let's make it harder. Let's say it's old.
Sure. So you want to know what medications they were on, if any.
Yep.
Or, for example, if it's been withheld because they were going to surgery, I don't know, some reason.
It's 2 o'clock in the afternoon. She's had all her normal morning meds, and the nurse has gone off to get the med chart for you in the meantime.
Hmm.
Are you worried?
Am I worried?
Because if you leave it alone, the nurse is just going to say, the heart rate's still fast. You haven't actually fixed anything. Do you have to fix anything?
Probably.
What would you do and why?
Hmm.
I'm picking on you a bit now because now you're talking to me.
That's alright. Well, I can take you wrong.
Yeah, that's all the point is.
So I guess, so I want to know if she wasn't in, I can't remember if she was in fast AF or not.
Yep,
She
she's
was?
fast. Yep, 130, let's say.
So I don't know her other comorbidities, but generally speaking, that's not a good thing. So you'd want to, you want to lower the rate.
Yep.
And the way you do that is with rate controlling agents such as beta blockers.
Sure.
Got it,
Yeah, what's on the board? Yeah. Yeah.
So, I mean, as an intern, particularly starting out, I'd be phoning my reg pretty quickly.
Good.
But the things
Yes.
that I could be doing is finding her old and new ECGs.
Yep, good.
And putting some monitoring on her, making sure she's not underloaded and doesn't have any reversible causes from perhaps that paroxysmal or other ones that you can think of.
Yeah. All right, that's a pretty good start actually. So, let's say you decide for whatever reason you're going to rate control it. Beta blockers are always a good way to go. Oral beta blockers. If someone's on their regular meds and it's close enough, you can give them the regular meds again. If they don't have regular meds for AF, rate control works. Beta blockers are good. I'd steer clear of the calcium channel blockers, the central ones. People don't tend to use them too often. Beta blockers are easy. 12.5, 25 for the top of the orally. Never really hurt anyone. Now there's a caveat to that. So, question up the top is, do you have to treat rapid AF? So, normally, you're about to unfortunately go into a world where any time there is a number that is outside of some predefined normal range, you're going to get paged about it. And if you don't answer it quick enough, then there's going to be a med call. All right. So, what you have to start doing from now on, which is going to suck, unfortunately, it's not as easy as when the number's abnormal. You just have to fix the number, because fixing the number can be a problem, right? So, Is fast AF a problem? Probably not really, let's be honest. If they've got signs of shock, if they're hypotensive, if they're dizzy, if they've got chest pain, if they've got ECG changes, blah, 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 all that sort of shit, right? Then sure, you can treat it. But common reasons that people will be in rapid AF, sort of the same common reasons that people will be in a sinus tachycardia, except they've got AF, and their heart just goes a little bit faster, and more of those beats get transmitted through, and so you get a higher ventricular rate, right? So what are some of the things that cause commonly you to just have a tachycardia when you're in hospital?
Fever.
Fever, cool. What goes on with fevers? The people go to hospital for. Infections, good. What else? Pain, good. So would you beta block someone if they've got an infection or they've got pain? No. So you don't do it for AF either. Right? So it's a bit, even though there's an easy way to do it, beta blocker, calcium channel blocker if you really want to, amiodarone if they're unstable, you don't have to actually do it very often. But you have to be able to explain why you're not doing it. Because often, all the people really want is a plan. So the number's abnormal, so be it. If you can tell them why it's abnormal and explain that it's okay for it to be abnormal, and you're right, then it's okay, right? So you don't have to treat every AF. And this is probably one of the biggest mistakes that I'd see like junior doctors do. Someone's in AF, they give a beta blocker. Now, unfortunately, that person that was in AF is actually an 85-year-old who's coming in with pneumonia, and they were actually undergoing a bit of their sort of SIRS response, if we still use that term, and they were tachycardic because of an infection. And that might have been what's actually holding their blood pressure up to a relatively normal range, right? And then you just dumped it.
So then would there be some situations where, like for those, not the pirate line, where like fluids or like a small fluid bolus could fix AF then? Yeah,
of course, definitely. Under volume people can go into AF, over volume people can go into AF. So taking fluid off can sometimes work.
Yeah.
If you've got someone with like severe heart failure, systolic or diastolic heart failure, and the atrium is stretched, it can disrupt the normal rhythm, the normal electrical conduction of the circuit. So getting fluid off can sometimes help. Post-op cardiac patients, like a third of them develop a new AF, let alone the ones that already have AF. You don't treat them all, right? So it's just about making sure that you, not only do you think about what's actually going on, but try and work out why it could be going on, and come up with a reason about whether you have to do something. Yeah? And right past your edge, or resident, or another routine, whatever. Yeah? Electrolytes, blah, blah. Magnesium above 1, K above 4. They're two numbers everyone always likes. Magnesium actually helps, potassium, not so much. So what about this person? Who's the person?
That's not very sharp.
Yeah. They're a bit worse. It's fast AF. Yeah. So what do you do for someone that's got tachyarrhythmia, has signs of shock? What do we teach normally? If you were doing your ALS course right now, what would we be teaching you? Always ABCD, I'll give you that, sure. What specifically about unstable tachyarrhythmias are you supposed to do? Yep, shock. How do you shock? Yeah. I guess if I ask a stupid question, I'll get that sort of answer fair. ABC is good. Shocking is good. What else can we use it? We used it before. What else can you use? If someone's been doing ICU at the moment, they might have seen it a fair bit because it's our favourite blade drug in the world. What do we use for slowing down every heart? Amiodarone. Yeah. Shocks don't really work that often, I'll be honest. So they sometimes work okay for people that are flicked into new AF for some reason without an obvious irritant cause. So you get someone with ED, no previous history of AF, they've just had a funny heart rate or something this morning, and they're in AF now. and you can shock them out, but sometimes that works if you don't decide to send them home for a day, which you will be doing. For most people, it doesn't work. So amiodarone is normally the way you do it. Right? Will you have to do that? No, of course not. Right? So even though I'm explaining what it is you would do in theory, you don't have to do it because you'd be calling for help. Yeah? But at least if this helps ease some of the comfort about what you might have to do or what you might want to get ready. So what in reality would you be doing? So let's say real situation, real life, forget the treatment per se. Unstable person, you're the first person to respond, you've called for help. What do you do in the meantime?
ABC.
ABC, cool. So what does ABC entail?
So that might be little things like it depends if that patient's still conscious, but talk to them.
Yeah, they're conscious.
Put the bed flat, assess their breathing, do they need any oxygen support?
Yeah.
When you've called for help, you can sort of ask nurse to bring like the crash trolley and
Sure, good.
all those other bits and pieces and
Cool.
cannula trolley.
Cannula, good.
Yeah.
It's the most important part.
And then even see if they've got cannulas and
Yeah. Cannula is the most important part. Realistically, we can do everything in the world. If we don't have IV access, all we can do is really CPR. So we can wait for that if we want to. Or you can get a cannula, right? So if you're an intern, first responder, someone doesn't have IV access, get it quick. It's probably the best thing to do, yeah? And then once everyone else is getting everything else, if we come and you've got access, you've done more than most people would ever have done, guaranteed, 100%. Most people do, to be honest, most people freak out, so they do simple things like put an oxygen mask on, stand in the corner and almost cry, that sort of stuff. If you get a cannula in, you're doing really well. Yeah, you shock and then you get told to go away because you never get to see the fun stuff, unfortunately, as an intern. So, young person with a fast heart rate. Same thing, don't bother reading it, she looks okay. What's that?
But it doesn't look like as sawtoothy as I would expect it to.
No, it doesn't look sawtoothy, does it?
These are fairly regular.
It's regular, good.
Rapid.
Pretty fast, yep.
So SVT is narrow complex.
Yeah, sure, yep.
Or is it just size?
Is it a sinus tachy?
Yeah.
Yeah, that's what we all do if we get on the exercise bike.
Yeah.
Sinus tachycardia, right? So the difficult things that sometimes I'll leave there for a moment. The things that sometimes get odd. See here how like you get the T wave and the P wave that sort of merge into one. So you can imagine if they get a little bit faster, it becomes really hard to see the difference.
Yeah.
Yeah. So sometimes you get lucky. The reason I found this one because it's got a nice little camel hump, and that's what's called the camel hump, and that can be an indication of a T wave and then a P wave. You've got a P wave before every QRS. Doesn't have to be regular, it's still a sinus rhythm, right? Sinus is P wave with every QRS afterwards. Cool. We talked about before already the causes of sinus tachycardia. All that stuff up there. Common things are going to be people that are touch hypovolemic, pain, infection. They're really the big ones. The rest of them, you know, so be it. And similar to AF, slowing it down is not necessarily a good idea. So fast numbers, you know, high numbers don't necessarily mean you have to treat it, yeah? And often it can do someone harm. Imagine someone beat a block you while you were running on an exercise bike, right?
So what do you treat? Is it just if they're symptomatic?
No, not really if they're symptomatic. So I'd probably treat, I have beta blocked a sinus tachycardia before, and not accidentally, I'm sure I've accidentally done it lots of times, but I have on purpose done it before. And that was because it was an older person who was actually exhibiting dynamic ischemia as they were going fast. They were going too fast, their coronaries are not getting the blood they wanted, and they're effectively giving themselves an MI. So you slow it down. But that's something that you don't do then with like oral metoprolol and leave it for an hour and see how they go. That's like critical care environment, intravenous drugs, very tight control, very slowly bring it down, like just to the precipice where they're no longer having a heart attack. Yeah. Otherwise, don't worry about it normally. Look for why. That's probably a better thing to do. Fluid, that always helps. In this case, she was anxious, if I let you read it, but it was a bit boring, so. And then there's this. So this is the other one that happens. Not very common. Young person, pretty well. Fast heart rate. Telling you it's thumping in their chest. So ECGs are actually the easiest thing in the world, right? Yeah, I know it sounds stupid when I say that out loud, right? But I hated them, absolutely hated them. I honestly, I reckon I finished med school and I couldn't tell you what VFs looked like. Like shitting, I had no idea about ECGs. But they're actually really, really simple. They're really simple to get most of the things you want to get most of the time, right? Look for P waves, look for QRS complexes, look to see if they're together or if they're not together. Look to see if the QRS is wide or narrow. That sort of gives you most of your information every time. Yeah? All the fancy stuff about axis deviation, fascicular blocks, even heart blocks, who the fuck cares, right? Really. So what's happening here? Fast or slow? Fast. Right? Are there P waves?
No.
No, you can't really see any, can you? It's good.
How do you know, sorry to stop, how do you know it's a T wave, not a P wave?
Good question. You don't.
Okay.
Yeah. So.
But everyone in this room unanimously decided it was not P waves.
So was that?
Everyone in this room unanimously decided it was not P waves, and I just want to know.
Probably because they had to guess.
Okay.
Yeah. So you know it's a T wave because it comes after QRS. It looks like it's
But
about.
could be a P wave before, you know?
Yeah, it could
Is
be.
it a T wave?
So
Could you have P waves or no T waves?
could you have P waves and no
Could
T
they
waves?
be all P waves and not T waves?
I don't think.
So could they all be P waves and T waves?
Yeah, you have to have a T wave.
So yes, you have to have a T wave. You actually do technically have to have a P wave. The question that you have to ask yourself is, what are you actually looking at? Because all you're looking at is an amalgamation, like addition of different electrical signals, right? If you've got 2 units of electrical signal that way and 1 unit that way, it adds together to only be 1 unit that way, and that's what it shows you. So it doesn't actually tell you exactly what's going on. It just adds together all the electrical impulses it gets and then averages them out and says, at this second, or millisecond, the average direction of the vector of all the electricity is going that direction by this much, and it gives you a little deflection, right? So what actually happens in these scenarios is a P wave, is it a T wave? Fuck knows, it's probably both, and that's what's actually happening. The P wave and the T wave may all be actually coinciding, so all you're really seeing is a taller wave because it's the positive of the P wave, which is a bit smaller, and the positive of the T wave, which is a bit bigger, giving you a positive of both together, right? So it's sometimes difficult to know exactly what's going on.
So it's radios.
Yeah. Yeah. So SVT.
No.
SVT is a stupid term. I hate it. What's SVT? Supraventricular tachycardia. So sinus tachycardia is SVT. AF is SVT. Flutter is SVT. What do we talk about when we say SVT? We talk about the AVNRTs or the AVNRTs. So the nodal re-entry tachyarrhythmias, or just the re-entry tachyarrhythmias. That's what we classically call SVT. But SVT is anything that comes from above the ventricle and makes your heart rate go faster than 100. Yeah? So if you want to sound really punctilious, you can say that next time. But otherwise, SVT. Treatment of SVT. Vagal maneuvers, good. How do you make someone do a vagal maneuver? Blowing their thumb. Yeah, it's good. That'll work.
Get
Yeah.
them to blow on their own thumb.
Yeah, not your thumb. That's really weird. Yeah, I'll agree with that.
Or like the syringe.
You do a syringe, yeah. Yeah. Carotid sinus massage, yeah. It's the next step. Vagals, so blowing on a syringe, you can get people to you can take off the blood pressure cuff and blow into the sphygmomanometer and actually make them try and create pressure that way. The syringe is sometimes hard because it's hard to get a good seal. Doesn't really matter what you do because it never really works anyway, right? Carotid massage, sinus massage. Who do you not want to do that in?
People with
pretty much everyone that's not like 20 years old, right? Because inevitably everyone's got a horror story of doing it in someone and they stroke it down because you've flipped off a clot.
Is it literally like a massage of carotid?
Yeah, so you've got to go at the carotid sinus. So where you basically get the bifurcation of common carotid into internal and external carotid. There's a big lump, the carotid sinus. It sits basically at the angle of the jaw. So it sits just behind there, that's where you've got to rub it. And you literally just massage it, like rub it for a little bit, and it creates an increased vagal tone. So when that all doesn't work and when someone's shitting themselves, have you ever heard of adenosine before? Yeah? Has everyone ever given it or seen it given before? Do you know what it does to an ECG?
Flatlines for a little bit, eh? Or,
Yeah.
That's not concerning
Quite
at all.
horrifying. Yeah. So if you're going to consider, luckily it's not anywhere except for like on met trolleys and stuff like that. You're going to give adenosine, they have that cardiac monitor on, they have to have defib pads on. You have to tell them because people know that that happens to their heart. Like they don't know it's actually that happening, but they feel like they're dying, right? So you have to tell them.
What do you feel like?
Sorry?
Do you feel like nauseous?
Yeah, that's a classic script. They literally just feel like they're going to die, honestly. That's what they describe. They sit there and they say, everything just felt like it was crushing on me and I just felt like I was about to like stop breathing and die because their heart stops. Right? So normally you do sometimes get Pwave still, which difficult to see if they are any in there. There's maybe arguably one here somewhere, maybe another one here, right? It just blocks basically the transition between atrium and between ventricles, right, through the AV node. Often it'll kick them back out. Don't worry about anything else. All right, here's another spot diagnosis for the top one.
Right, the one by one.
The top one, to start. WolffParkinsonWhite. Yeah, so why is it WolffParkinsonWhite? What gives it away?
Short PR and slowed up stroke QR.
Yeah, what's that slowed up stroke called? Delta wave. Yeah, cool. Right. Now you're going to cop the next question. So what's the bottom one? Good. Looks like VT, doesn't it? It's not VT, right? There's a reason WolffParkinsonWhite is at the top. Someone that's actually probably gone into like AF with WolffParkinsonWhite as well, right? But here's the thing. If you look at that and you say it's VT, and you treat it like it's VT, you're actually doing the right thing. If you treat it like it's AF and you try and give them amiodarone or something or a beta blocker, you might kill them, right? So if you think it's VT, which it looks like, we all sort of agree it looks sort of VT-like, broad, complex. It's not really totally regular, but it doesn't have to be regular. It never really is. It's never that nice, like broad, complex, stable, regular thing, right? So it's just broad, complex. It looks shit, and it doesn't look like VF. So that your diagnosis of VT, right? So that's WolffParkinsonWhite with re-entry tachyarrhythmias. You're shocked, as opposed to slowing them down. Yeah? You haven't happy with WolffParkinsonWhite up top? You hardly ever see it. But we love talking about it.
So is that people with WolffParkinsonWhite are more likely to have the re-entry?
Not necessarily, but if they get a re-entry tachyarrhythmia, then you have to be careful.
Those people, because they've already, they've got the puppets, they've got the circuit.
Yep.
If they were to have any of those things that cause them to have sinus tachy, then that's what could happen. Is that?
No, re-entry tachyarrhythmias are generally different. That's like a structural problem within the heart.
Yeah.
Whether it's around the actual node or whether it's a non-nodal re-entry tachyarrhythmia.
Yeah.
It's not really something you're just flicking it out of, like because you're unwell. It's generally an underlying issue with the heart. All right, another fast heart rate. This person looks well, I'm not going to make you read it. They're fine. Fast heart rate in a 78-year-old guy with pneumonia. And this is your ECG. What does it look like?
Junctional.
What does junctional mean?
That.
No, it's not junctional. So junctional arrhythmia or a junctional rhythm is when you actually get a narrow QRS complex that's essentially come out of the junction, right? So it's come out of essentially where the AV node sits without there being a supraventricular or an SA nodal electrical pathway. So you basically get a narrow QRS with no P wave before.
Is this one?
Yes, this is flutter. Can you sort of see the sawtooth pattern? Can you sort of see how, like, over here especially, you get like up and down. There's a QRS in between, but that's because basically the P wave in this scenario lines up almost exactly as it more often than it does with the QRS. So you sort of get this odd sawtooth. Now, if I was able to turn it upside down, often looks it's a bit easier when you get your head out of looking at ECGs, like by turning upside down, the sawtooth pattern becomes really obvious, right? There are different ways to. There are two different types, like an anti-clockwise and a clockwise flutter. Who cares? Doesn't matter. That's flutter. What do you do with flutter? Same things with AF, right? So AF and flutter are essentially the same thing.
Yeah, both of us that kind of continue.
Sorry?
AF and flutter will continue, but if there's something.
Not particularly, no. Flutter is when you tend to get it's like a re-entry tachyarrhythmia around the atrium. And so you get this cyclical sending through of a single signal through to the ventricle. So it goes around, sends off, goes around, sends off, goes around, as opposed to a normal SA node that goes down and sends it off, right? AF is just everywhere, multifocal. Everywhere's firing all at once. So it's not coming from anywhere in particular. Yeah?
Are you more likely to, you know, for like AF, like whatever treatment, like
Yep.
the flutter, do you need to treat that a bit more quickly because it's a bit,
No.
it's not the same?
No, it's just the same. People often go in and out of flutter. Doesn't really matter. It's not very common either, to be honest.
So the similar courses to AF opposed to flutter in terms of precipitating.
Relatively speaking, yeah. To be honest, those other causes are pretty much the cause of every arrhythmia, most of the time. Ischemia, PEs, overload, infection, cytokines, yeah, it's the same stuff. Yeah.
Do you always try to treat flutter if it continues with the radio frequency ablation to get rid of flutter?
It's relatively uncommon, to be honest. It's definitely not done emergently in hospital.
Yeah.
That's something that gets done by a private cardiologist who wants to make way too much money. But no, it's pretty uncommon. So it doesn't really matter. Yeah. That's what happens if you give adenosine to someone that has flutter. So if you think it's what we were talking about, like SVT, you know, your re-entry arrhythmias, they've actually got flutter, that's what we'll see. So you get the flutter waves that come out really nicely underneath. Doesn't hurt them, adenosine lasts a few seconds. So they pick back up, hopefully.
And if it is SVT, then you're treating.
Well, so
adenosine?
yeah, so the thing is, if it's flutter and you do it,
Yeah.
then it'll generally go straight back into it. Because you've still got all those electrical signals that are just going to recapture and start transmitting to the ventricle again. So you'll still get a tachyarrhythmia on the other side. So you just slow it down with the same sort of stuff that you do for previously for AF if you need to slow it down. You don't need to slow them all down. Yeah? And you don't, also I think, I did write there that you've given adenosine because you weren't sure in the scenario. You don't actually have to give adenosine to make sure it's flutter, right? So you can treat it as if it's AF anyway, A, beta block them, let them get better normally, yeah?
Do they feel as bad with adenosine if they've got flutter?
Yeah.
Okay.
Yeah. It stops.
Even though there's something going on still. Yeah.
There's something going on. It's just the electricity running around the atrium. There's still the heart's not pumping. Yeah.
Is there a medication that we expected to be able to?
No. No. Never. Ever. So, like, as an aside from this lecture, because we've probably only got like 1 or 2 more cases or something, what do you actually do in internship? You know, like, let's be honest. We sort of, like, the initiative that we want you to show is that you assess a problem, you can identify when you rapidly need to escalate and when you have time to come up with your own plan, and then you review your plan with a senior. That's what you want. That's what we want you to do in internship. And what you actually do is that in the job is a lot of paperwork, discharge summaries, running around in ward rounds, trying to write things down, trying to understand what the fuck someone's saying, hopefully not stuffing it all up, listening to the nurses. That's what you're doing internship, right? What scares people is that you think you have to do this stuff. You don't. You would never have to do this stuff. If you walked in to, let's say, this guy here, who's bradycardic, drowsy, signs of shock, and you called a met call and then stood there and pissed your pants, that'd be fine. Like, we don't expect you to do anything more. Just the same way, I'm sure if I was talking to my consultants right now, they wouldn't expect me to do anything more than piss my pants if I was in the room with someone unwell. Yeah? So that's the baseline expectation, that you can call for help and escalate quickly and get help there. If you do anything extra, if you get a cannula, if you come up with a plan, great, brilliant, you're doing well. You're not expected to do any of this stuff. Unfortunately, the shit thing is that the patients don't know that you're only an intern. So their body will do this sort of shitty stuff to you, and you're going to be the first one they're dealing with. Yeah? And that's what scares people most of the time. So what do you do for bradyarrhythmias? So I'm not going to teach you how to do paperwork.
ECG.
No, we don't have an ECG, so it's bradyarrhythmia.
Met call.
Yeah, sure, met call, cool. Now what? Adrenaline.
Is it atropine?
Atropine, it's one of the other A's. Atropine, that's a good one to go to start with. How much atropine do you give? Whatever comes in the vial. Pretty much most medications you can probably give by the vial. There are a few exceptions. Most things, there's a reason that comes in that amount in the vial. It's because it works in that amount. Yeah. So this is all ALS sort of stuff. Bradyarrhythmia, signs of shock. You can try atropine, 500 to 600 mics, depending on which hospital you're at, because some places have different vial sizes, up to a maximum of 3 milligrams. The only reason for that is because by that stage you should have gone on to your next step because atropine is not working. Yeah, atropine only buys you time, so it just blunts the vagal response, buys you time. Yeah? After that, again, things like adrenaline, isoprenaline, stuff that you don't have to start, stuff that no one expects you to give. I'd be very scared if you were giving that on the ward. All right, but that's where it goes to. Or pacing, external, internal, whatever you do. Yeah.
How often do you need to use pacing?
Not very often.
So atropine generally sorts you out really well? Is that
no, that also doesn't work very often.
Okay.
So it's often in the middle. So if you have someone that has a bradyarrhythmia, that is a non-transient bradyarrhythmia for which they're exhibiting signs of shock, atropine, the only real thing it does is it buys you time whilst you're getting the therapy that's actually going to be long-lasting ready. Right. And that therapy is adrenaline or isoprenaline, generally. And that buys you time until you either let the heart hopefully go back to normal because someone came in and presented with with shock and hopefully will go back to normal, work out why it's abnormal, or get your next longer term thing, which is a pacemaker. Yeah. Transcutaneous pacing doesn't I've seen it once or twice, just, post MRIs or something that you thrombolyze. And that's about it really. What's that? Are there P waves? Yeah, so we'll argue that there are probably P waves like this thing. The thing about having ECGs run up and down is that anything that happens on this spot here has to be happening at the same spot underneath, so you can try and correlate them. P wave. It's arguably a P wave here. Probably P wave here, P wave here, P wave here, P wave here if someone was moving a lot. So there's P waves.
One is good.
Sorry?
One with a wave without a QRS. Yeah.
Yeah, there's lots of them without QRS, I'd say. I reckon that one's not conducting, that one's not conducting, that's not conducting. I'd even say that's not conducting, to be honest. Even though it looks like it's close, it's probably just by accident. So this is complete heart block. Now, what else looks really wrong about this ECG, right? So, yeah, right? So it doesn't matter. You don't have to know what the fuck you're looking at. You look at it, you're like, well, that looks bad. Yeah, it's bad.
Yeah.
So where's the ST elevation? Let's see. Why don't we forget? See if I cover my hands here, it doesn't. Forget the bottom three for a sec, because those are extra leads that someone's put on there. Normally you get basically these top four, right? That's what you normally get. Your 1, 2, 3, AVR, AVL, AVF, and then your precordial leads, V1 through V6, right? And then someone gives you a rhythm strip down the bottom so that you can try and measure appropriately all these different leads with different shit going on to hopefully some sort of baseline and try and make sense of it, right? That's why the rhythm strip's there at the bottom. So where's the ST elevation?
2, 3.
AVF. Yeah. AVL. V3. Where's the isoelectric line? So where's the baseline? Up here. Yeah, depression. Yeah. If you want to sound really smart using the terms that we saw at the start of the lecture, in that little table that was on the bottom right-hand screen, we talked about inferior, anterolateral, septal. What would you say is going on right now?
ST elevation of the inferior leads with reciprocal depression in the anterolateral leads.
Yeah, that's almost right, yeah. I'd argue septal as well. So V1, V3 is septal leads classically, anterior is V3, V4, and your lateral sort of tends to go 5, 6, 1 and AVL. It's the circumflex wrapping around the back, yeah? But yeah, inferior ST elevation with reciprocal, septal, anterior, and some distal lateral distal depression. Yeah? So what's that called? STEMI. Yeah. Happy with that? Yeah. What happens if you see that? Shit your pants. That's a big STEMI. Inferior STEMI. What did we say before happens when you knock out the right coronary artery? Sometimes. You what? You? Yeah, exactly. You can knock out some of the nodes and knock out some of the actual conducting pathways. You can get complete heart block, where the P waves just march on through, do their own thing, and none of them conduct. Yeah.
In a complete heart block, do you get narrow QRS or wide QRS?
It depends. So complete heart block, classically they say that complete third-degree heart block is wide QRS because you have the impulse generating from somewhere below the AV node. You can still get impulse generating from within the AV node itself, or a little bit even higher. So it tends to give you no P wave, but still gives you a narrow QRS complex. The great thing about cardiology is if you show the same ECG to like 10 cardiologists, they've all probably got a slight different interpretation on what it is, depending on which paper they've just read. So most of the time, it doesn't matter about all the little shit, like as long as you can get the big stuff right. STEMIs, big stuff. Arrhythmias, big stuff. Tachy, arrhythmias, big stuff. Right?
No, so here
Definitely.
you can go, it looks like a STEMI.
Yeah.
Yes, I'll call a MET call, but I almost feel as though a MET call isn't enough in the sense that would you want cardiology to be here ASAP?
Yeah, so I would.
So what would you do with the intern?
So what I do in reality, so I definitely call a MET call because a MET call will get you someone within 5 minutes, generally, right? So our criteria, I think, is 10 minutes for a MET call response, or you upgrade it again to a second MET call. If that's not there within 5 minutes, then it gets upgraded to a code blue. So you're 15 minutes away from effectively having any senior help, right? What would I be doing in reality if I walked onto a ward? Like, let's say I was there as the MET call person without in the MET team, walked onto the ward and saw that ECG someone that had chest pain. I'd call the MET call and get IV access. The rest of it doesn't matter. The MET team will get there. You can call cardiology if you want to, but they'll say send through an ECG, and you got to take a photo, and it takes time, it takes forever, and they don't trust you to intern, your action is actually a STEMI, is it not, blah, 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 right? Get IV access, get off. That's sort of about what we need to do. Things happen. So, have how do I say this without sounding really like crass? People don't die very easily. Like bodies are really good at compensating. Even old people's bodies are really good at compensating a lot of the time. So more often what kills people is something massive that we're finding out about a day or two after the fact, i.e. when they present to ED and it's already been going on for days, as opposed to happening in front of you, right? If you gave this person aspirin GTN at the bedside, you may well get resolution of the ST segments and of some of the pain. You might not, but you might. Do you know what I mean? If you get it early enough. I think that is actually about it. That person died, I presume. I don't know, it just looked like a funky ECG. Didn't look good. So, last teaching session before internship. Any questions at all? You got an open mic for the next 20 minutes.
If they were hypotensive, would you still give GCN?
If they were hypotensive, I'd shit myself.
Yeah.
So if you've got someone that's had huge STEM who's hypotensive, you're in reality already pretty much fucked. Yeah, exactly. If you want, and again, here's another thing, call a code blue, who cares? Like, no one, there would be no one in the world that would be angry at you for calling a code blue if you saw that ECG and panic, right? People call code blues for, I mean, I had a code blue the other day in the video EEG monitoring ward, right? So we're admitting people to not give them medication and see when they seize. And I had a code blue for a seizure. Right? Now that's stupid. Pretty stupid, arguably. Especially because it was the nurses that work in that ward day in, day out doing it. Still don't get too angry, because you get there and at least it's not a real code blue, right? Most code blues are not actually cardiac arrests. So most code blues are people that have become, I think technically a code blue is unresponsive and altered breathing is enough to make the nurses trigger an immediate code blue. So anyone that has a vagal will be unresponsive and have a weird breathing pattern, and that's more often than not the code blues that we see. Yeah? Or other stupid things. When I say stupid, I just mean not cardiac arrest, not that it's stupid to call. Right? As an intern, you're not expected to know anything. Honestly, I can't stress this enough. Literally, if you walk in and you do your job effectively, you do the paperwork, you ask questions, you seem interested, and you're not an asshole, you're a good intern. Anything else is a bonus. Any bit of medicine you know is an absolute bonus, right? Don't expect you to learn anything in medicine at all, other than writing. Writing's helpful. Yeah? You learn the language so that you can translate and write down all the shit that we say. That's effectively what you do, right? So you're not expected to know anything. You want to know things, and you will know things, which is why we like to let you come up with plans. We make you do admissions, for example, so you can examine people, so you can come up with an idea about what's going on. It's really hard because when you're in internship, you haven't seen it before, and you get all the responsibility. You focus on really, really little things, and it's sometimes hard to get a global picture. So you'll focus on a little problem, on a cough, on a blood pressure being low, on a heart rate. Irrelevant, you might not think about why the heart rate's fast, why the blood pressure's low. Or even further, should we be treating it? Or even further, is a problem, right? You're not expected to.
For a met call,
yeah.
Are you aiming to get 2 candidates for every patient?
Not particularly. Yeah, I don't, again, it's my bias because I only see the sickest people in the hospital. So the met calls that I see are generally the least sick of the people because most of them stay on the ward, right? Do I expect 2 cannulas? No. Most of the time a met call is for a number that's abnormal, it's outside the normal range, and we have to get there and justify to someone why it's outside the normal range and why it's okay to be outside the normal range. That's what most met calls are for. Having said that, again, no one that's not an absolute arsehole, mind you. So I do preface this because there are lots of arseholes in medicine, right? But no one that's not an absolute arsehole would ever give a junior doctor any lip, or junior nurse for that matter, for calling a Met call if they're worried, right? So we routinely, like, we do a huddle at 1 o'clock in the morning. So tonight, 1 o'clock in the morning, I'll be up with the junior doctors overnight, asking them if everything's okay, if they've got any problems with anybody, and giving them my phone number. Why? They can call a Met call if they want, or if they want advice. Because what you'll start to learn as well is that, for me, it's easy, because I get to look after, when I do the Met call job, just the sick people outside of the unit, right? For a med reg that has 40 people on their list, it's really hard. And when you've only got a resident and an intern, it becomes really difficult to oversee everything, because you've got to go to your exam study, you're doing your clinics, you're trying to get your research done, impress the bosses as the registrar. And so then the residents and interns are sort of left to their own, right? So it would not surprise me at all, I doubt it's changed since I was an intern, if you often feel like you have absolutely no support. You're there, you've tried to call the med reg who's in clinic and can't get back to you. Or you've tried to page a surge reg who's in theatre scrub, right? So no one has any issues if you want to call the ICU reg and say, can you just kind of run this past me? Generally not just, small things. We might not want you calling all the time about that. But if you're worried or if you feel stuck, no one has a problem with that, yeah? And I think that's one of the things to remember going into next year. No one wants to call for help. There's like a bit of a thing about calling for help. No one wants to do Met call. The nurses do it really well. They'll Met call for fucking anything, right? But no doctor wants to call a Met call, ever, ever. I have to convince them to call a Met call because I don't have the nurse that actually wheels the trolley, right? So it's okay to ask for help. It's expected to ask for help. If you're not asking for help, we get worried about you. And by worried, I mean worried that you're doing shit that we shouldn't even know about. And we notice when you don't ask for help. Yeah? So come up with a plan, that's fine. Ask us, that's fine. If you don't have support with you, escalate, that's fine. Yeah? Anything else that worries you about internship that I can help with?
How much can you prepare for internship, and how much of it is learning on the job?
I'd say, well, it's a difficult question to ask me because I basically didn't turn up to med school. So I trained at PAs all day. So for me, it was all learning on the job. I think there's a huge difference between what you do as a med student and what you do as an intern. So there's a huge difference between being a good medical student and being a good doctor. Yeah. And I think that everyone will sort of find their own little niche and how they like to do things. And probably your own personality and how you approach a situation will then dictate what you end up doing. So at ASPE, we'll do radiology, right? Because you don't have to talk to people. Easy. If you go to gym, you do orthopedics. But yeah, it helps, and the knowledge helps to make you feel more comfortable. But ultimately, the way I viewed it was every hour that you're at work is like an hour of forced study. But it's like intense forced study because you're really worried about getting something wrong because you don't want to fuck up, right? So I did a lot of extra shifts because I wanted to study, so I had to study more, right? But you'll find that you'll pick things up as you go. So things like antibiotic doses, if you're at the Austin, then you're lucky because you get to type into the computer and it gives you all the answers. It's brilliant. I love it. Otherwise, you'll learn. Everyone has their own opinion about which antibiotics they want to give, about what allergies they want to give, about what medications they want to give, what dose they start at. So you just learn as you go with each unit. It's too much stronger because you've been moved by anymore. Yeah, so there's not much that we realistically expect you to know. I really can't stress that enough because if I make you believe that we actually don't want you to know anything, then you won't feel bad for asking for help because we want you to ask for help, yeah? It's your first year and you will do a ward round and the boss that's there with you has worked for 40 years, is an internationally renowned cardiologist who's published papers, who's created the fucking cath lab. Like, do you know what I mean? So you're not expected to know anything like what they know. Yeah? Anything else? All good? If you guys need anything, any help, you're always welcome to message either on Facebook, or if my number's somewhere floating around, I'm sure it is, email. If I see a word, call. Yeah? It's a hard year, but it's awesome. It's really cool. You'll love it. Yeah?
Thank you very much.
Thanks very much.
No problem. Thank you very much.
Yeah.
We all want to bring it.
Yeah.